to give you a brief introduction. So it has been known for decades that a certain subset of patients with acute viral infection will fail to fully recover, even if that infection did not appear particularly severe. And these patients are often given the diagnostic label of myalgic encephalomyelitis or chronic fatigue syndrome, which is abbreviated capital M, capital E / capital CFS. Michael Van Elzacker is a neuroscientist who since 2015 has built an ME/CFS research lab here at Mass General Hospital with a broad research program that focuses on neuroimaging. He has been invited to speak about ME/CFS at the NIH and asked by the government of the Netherlands to advise them as they develop the 28 million euro national research program for ME/CFS. So very pleased to present you with Michael Van Elzacker.
Hey, thanks very much. I think that the Dutch government saw my last name and assumed that I was Dutch, which of course, you know, I'm a typical American. I don't speak the language. I've never been there, but I was quite honored to have my distant cousins ask me to help them with that. It was a real political struggle there to try and get a research program going. And it's sort of surreal that we've been shouting from the sidelines about this condition where people get a apparently viral illness in most cases, not all, and then have long-term consequences that can sometimes last decades and be very debilitating. We've been shouting and screaming that this is a real thing. And then suddenly the COVID pandemic hit. And, you know, it was really front and center as a lot of people dealt with long COVID. So I'm going to talk a little bit about the dynamic of, you know, some ways to think about long COVID, maybe through the lens of ME/CFS. So this is just disclosure. I wish that I was getting rich off of this, but it's not a good way to make a lot of money. So this is, you know, just some headlines. Obviously, this has been a really prominent thing in our culture as people started to become more and more aware of long COVID. You invited Hannah Davis to speak, and she presented some data. Here's just some symptoms that I'm sure she talked a lot about. You know, generally speaking, what people experience with these sort of syndromes, and they are syndromes, sort of symptom-based labels. In this case, we know what triggered it. In many cases, we don't. Basically, the feeling of being sick, like an ongoing flu, a failure of recovery from exercise, a lot of autonomic symptoms, or, you know, subjective autonomic symptoms, often when changing posture. And then, you know, diffuse pain is another common one. And so right away, I think people from our world of ME/CFS were pointing out that there was quite an overlap. This is Tony Komaroff from Brigham and Women's, who was one of the folks that was sent. There was an outbreak of some apparently infectious illness in 1984, 85 in Incline Village, Nevada, that was causing a lot of lingering consequences in people. And the CDC sent investigators, and he was one of the folks that went to investigate that. Still to this day, a lot of people who were sick then are still struggling with ongoing symptoms. So if you think about those long COVID symptoms that Hannah's hard work put together, it really overlaps with the international consensus criteria of ME, myalgic encephalomyelitis. Tends to be the preferred name among patients because the term fatigue tends to be kind of trivializing. Oh, I'm having holiday fatigue in mid-December. And, you know, the actual evidence for encephalomyelitis is not particularly strong. There's some evidence, but it needs to be stronger. And that's one of the things that we're sort of working on to understand if that's a central mechanism. So again, sort of sickness, recovery from exercise is pretty central. A lot of what folks call brain fog, difficulty concentrating, pain, and again, autonomic type symptoms and pain. So some things to think about. A lot of patients with ME/CFS, female patients, for example, have recurrent UTIs sometimes, and we'll talk a little bit about why that might be. Sensitivities to food and chemicals are a common one, maybe related to a glial priming mechanism that I'll talk about a little bit later. We don't know that. And then generally speaking, autonomic problems, apparently trouble sort of producing energy and things like that. A little bit different in kids. Interesting, joint hypermobility. appears to be at least some kind of a risk factor. It may be part of the disease process, it's not really clear, but it does seem to be overrepresented in folks with ME/CFS. We think maybe it has something to do with the sort of elasticity of vasculature, but we're not exactly sure. We're sort of looking into that. So along with my colleague, Dr. Pralal, recently wrote a review article on this topic that sort of goes through what I'm going to talk about today in a lot more detail with a lot more citations. So you can look that up if you're interested. So, you know, when COVID came out, of course, we all kind of knew what was coming. And this comes from the legacy of myalgic encephalomyelitis. So this is a paper from the Lancet in 1956 that followed up another outbreak in a hospital, the Royal Free Hospital in London in 1955, in which a lot of nurses got sick at the same time in the nurses' quarters, and a lot failed to recover. That was taken by some years later upon reanalysis. The very fact that they were women nurses all sick at the same time was taken as sort of prima facie evidence of a mass hysteria. And we're still fighting that today. The idea that these illnesses are more common in women than men. And, you know, we're fighting against that sort of stigma still. That's where the term benign myalgic encephalomyelitis was coined. In that case, it was to draw a distinction with polio. At the time, polio was you know, the name of an illness that later became the name of a virus. But there are a bunch of enteroviruses that seem to cause similar problems as what's now the polio virus. These are outbreaks in the 40s and 50s that were leading to these long-term consequences, where in about a third of folks didn't seem to recover particularly well. There was actually an outbreak in Akureyri, Iceland. An MD there named Bjorn Sigurdsson was studying that, thought, you know, maybe it was brought into the island by sheep or something, but he was sort of arguing that myalgic encephalomyelitis argued for a cause, and they weren't really sure that that was the cause yet. And see, he argued against using that as a name, but we're still sort of using it today. But it turns out that, you know, in addition to these, you know, and again, in the mid 40s, certainly didn't have PCR. So we don't really know what was the causative agent. As of 2005, even known viral encephalitis only found an identifying pathogen about a third of the time. So it's still hard to know what's causing symptoms in many cases. If you know what you're looking for, it's a lot easier to test for, which we do in the case of COVID. But it turns out that it really is the case that these sort of long-term consequences follow a lot of illnesses. So there's a post-Ebola syndrome in which survivors, in this case, over 80 survivors of Ebola, reported, again, pain, headache and neurological symptoms, ocular problems, which I'll come back to in a moment. Post-Zika, Guillain-Barré is one of the consequences, which again is one of the consequences sometimes of the SARS-CoV-2 virus, probably due to a molecular mimicry, in which the immune system is trying to attack some pathogen, but there's cross-reactivity. Post-MERS, so we're getting into the coronaviruses that are very similar to SARS-CoV-2. And here again, we see carbon monoxide extraction, reduced exercise capacity. So again, trouble with exercise. And here they report, you know, depression and anxiety, which is pretty common. But, you know, I think it's important to remember the directionality of this, that the illness is causing the depression and the anxiety. And most of the time, it's not happening in the other direction. Where remember that if we inject people with Hep C with interferons, we're going to trigger a depressive episode about half of the time, just from sort of injecting pure inflammation. They lead to psychiatric consequences. And that doesn't mean that the anxiety and depression are causing the sickness feeling. And then even closer to home is the SARS-CoV-1. Very similar, musculoskeletal pain, fatigue, depression in some, trouble sleeping. So we get into some of that here. The pattern of post-viral, post in scare quotes, which I'll talk about in a moment, is a pattern of ME/CFS. And to tease that, it's that human beings are not sterile. So there's some lessons from ME/CFS that I'd like to impart on the long COVID field, sort of broad lessons. So one is that it's unlikely to be the exact same problem in all patients. So a lot of people who are new to this world really want to, from good intentions, find the magic bullet. This is the answer. We found the protein. There's people arguing that it's a single metabolic function, or that it's a single even ion channel that's gone wrong in these folks. And we think that that's sort of unlikely, that it's going to be sort of one problem in everybody. It is a symptom-based syndrome diagnosis. Many things can be going wrong and they're not mutually exclusive, which is hard, right? That's really hard for case control studies, group statistics. I think if you were to use the phrase personalized medicine in front of a bunch of MDs, they would stand up and clap. This is personalized medicine. This is what it looks like. This is where it needs to happen. Simple testing very often returns false negatives. So you'll see these patients say, well, my doctor did a test and it turns out that I don't have an infection. And you have to dig in a little bit and say, well, you looked in blood. Where else did you look? What did you look for? What was the testing? The onsetting pathogen doesn't enter a sterile body, and that includes SARS-CoV-2. So one of the big shifts in medicine over the next 15 years, I suspect, is going to be the recognition that we're walking ecosystems, and that those ecosystems can be disrupted by an acute infection or pathogen. And we know a little bit about that I'll get into in a bit. The thoughtful research design really matters. And again, you have to think carefully about group statistics when there's an individualized problem. And then the behavior of the onsetting pathogen probably matters. A concept that I talk a little bit about sometimes is equifinality, in which there's an endpoint that can be reached by multiple destinations, right? So if you see a forest fire, it could have been a careless camper, it could have been fireworks, it could have been lightning. So at the end result is a forest fire, but it didn't necessarily start in the same way. And I think this is probably true, even within the knowing that SARS-CoV-2 is the onsetting for all these problems. So I'd like to just go through these one at a time. And the idea that the acute actions of SARS-CoV-2 may be informing the long-term effects of SARS-CoV-2. So its ability to infect and affect many cell types, the possibility of viral reservoirs, the immunosuppressive activity of SARS-CoV-2, which I think is important. We hear a lot about immune activation, and I'll get into that in a moment. A dysbiosis of microbiome that can be triggered, and glial priming, which I'll talk about in a bit. So the ability to infect many cell types, obviously the ACE2 receptor is all over the body in a majority of cell types, and it can cause injury. So this is just a graphic from a Wall Street Journal article. I mean, you guys know this better than me, that there can be a lot of different tissue types injured and damaged and things like that. And interestingly, it doesn't even, obviously, if someone's got a really severe infection or went through a lot in the emergency room, they are dealing with more difficult recovery, but it doesn't always follow that a more mild or moderate infection can't lead to long-term consequences. So in terms of affecting large tissue types, obviously coagulation is a big story with SARS-CoV-2. So this is a paper by Ricia Pretorius and Doug Kell, who do really cool work. And they basically finding some properties of the spike protein that really lead to hypercoagulation. And here's a review article where they talk a little bit about that. Doug Kell is a big shot researcher in the metabolomics world. And this is a preprint, not peer reviewed yet, but I talked to Ricia about this, and she's basically finding, without overhyping preprints, which we've learned a lesson, she's finding that she's seen these coagulation problems even in long COVID. And so they're actually starting a trial where they are in South Africa using anticoagulants, even simple things like aspirin. So something to think about. Viral reservoirs is something that I think we ought to take seriously and recognize the limits of what we can do in terms of testing for a pathogen anywhere in the body. It's controversial, but it's important to think about. So here's an example from Christian Gabler of viral reservoirs found in the gut after COVID-19. We know that there's a lot of sort of gut problems in acute COVID and in long COVID. This is from an MGH pediatric gastroenterologist, Alicio Fasano, who found gut reservoirs even in asymptomatic kids. And the MISC was found in kids, even in ones that didn't have a particularly severe case, sometimes even asymptomatic. Again, important to keep in mind that it doesn't follow as a 1-to-1 ratio of severe equals long-term. Sometimes it's not like that. And he also found gut reservoirs. So interestingly, this is an enterovirus stain from a gut biopsy in ME/CFS patients. That list in the Lancet was a lot of enteroviruses. So this is an MD named John Chia, who's been drilling at this problem for a really long time, trying to get people to listen to him. And here he found enterovirus VP1 protein and RNA in stomach biopsy specimens obtained from 165 ME/CFS patients with chronic abdominal complaints. That's important because it may not be the same driver in all cases. And so he focused in on people with overlapping symptoms. 82% of ME/CFS specimens stained positive for the protein compared to 20% of control specimens. And they were able to culture a non-cytolytic form from 5 of the specimens. Positive staining was found in repeat stomach biopsy samples taken 2 to 8 years later. So they were able to repeat within subjects of some of these patients. So this is the idea of the post-viral. We hear the word post a lot, post-viral illness. There's an assumption embedded in the word post that I think we ought to just be careful of. So post-Ebola, post-Zika that I talked about before were classic examples, right? Well, it turns out that even after you did blood tests for Ebola over and over again in people having long-term symptoms, it doesn't necessarily float around in the blood. That's a bad, dumb place for pathogens to float around. They're vulnerable there. They like to get into tissues and hide out, maybe make an uneasy truce with the immune system. So here they looked in semen. Again, the testes are kind of an immunoprivileged, quote unquote, site, and found virus in semen, including, interestingly, some of these men started new outbreaks, little mini outbreaks, without knowing that they have live viable virus in their testes. Again, this is a devastating virus, but it sort of kept an uneasy truce. It wasn't ravaging the vasculature like it normally does. When we find RNA floating around in blood, I think we got to think carefully about where that's coming from. RNA is degraded pretty rapidly in most cell types. So here's an example of an MD who found Ebola virus in his eye. Remember I talked about ocular problems in long Ebola? They found a viable virus in his eye years later. And he said, at the time, Crozier thought the problems were, quote, an immune-related Ebola complication, which I have to just editorialize for a moment. I think a lot of MDs are trained that the immune system is somehow humanity's greatest enemy. And I think we ought to be skeptical of that. There's probably a reason if the immune system is acting up, there's probably a reason, maybe not all cases, but I bet most of the time there's a reason. So if we see inflammation, inflammation isn't necessarily the problem. It's the smoke where there's sometimes fire. So here's an example of Zika, again, found in semen shedding in symptomatic men. And then some macaque studies showing that even after apparent clearance, so they tested blood to sort of prove a point. And despite not finding it in blood, it was found all over tissues after sacrifice. So again, it doesn't make sense for pathogen to just float around in blood. It makes the problem hard. It's hard to test for pathogens. Type 2 errors are just a problem. And it's maddening because people can become convinced that they're infected, even when they may not be, but it's very hard to rule out. So that's viral reservoirs, and it can happen beyond the gut because so many cell types can be infected. So here's an example. And it's not lost on me that they're advertising for an immunosuppressive here. Given that we're using dexamethasone a lot, I think, obviously, if someone's about to die, dexamethasone really, obviously, you have to tamp down the immune response, but it became something that was being used as sort of a first pass right away. Someone comes in and just hit him with the dex. I regret to say that I predict long-term problems in those folks. I hope I'm wrong. So here's an example where they just looked at 20 patients and found evolution and isolation of virus in these folks with immunosuppression. Here's sort of a famous case study that you guys probably already know of viral evolution in an immunosuppressed patient. And here's testing found the SARS-CoV-2 was found in monocytes, macrophages, and endothelial at the blood-air barrier, blood-testis barrier, and filtration barriers. And again, this is quite likely testing negative by nasal swab. There's case studies where people, one woman, for example, tragically had a miscarriage, tested negative in nasal swab and blood, but the placenta was positive. So this is a study. It's a preprint again. It's a little bit controversial. They found spike protein in monocytes long after infection. I'm waiting to see how this one does in peer review. I think it's interesting. Some people argue that the spike protein sheds. I would like to see evidence that it's not attached to live virus. I think that's an interesting question. And here's a case study in which part of long COVID for a small number of men was erectile dysfunction. They were getting surgery to try and treat that. And some tissue was removed, and they found viable virus in penile tissue. And that was what was driving, apparently what was driving the erectile dysfunction in these folks, where again, that was part of their long COVID. It's not going to be part of everybody's long COVID, obviously. So just a little bit of, let's just have some caution with the word post. And I'll circle back to that when we talk about the microbiome. The relating to persistence, I suppose, is the immunosuppressive activity of SARS-CoV-2. Now, again, the sort of narrative is that the immune system over responds to the COVID infection, which I guess it does. I mean, it can really cause a lot of problems, the immune system. But I would like to start to think of the immune system responding inefficiently rather than too much, because most successful pathogens sabotage the host immune response in some way, right? It makes sense that they would do that. So HIV is an obvious example, a dramatic example of sabotaging the immune system, but most successful pathogens do that at some level. So there's a reason that looking into type 1 interferons to fight SARS-CoV-2 has been sort of a potentially fruitful avenue, at least in vitro, because part of what SARS-CoV-2 does is to itself sabotage that type 1 interferon response. So the idea is that perhaps in an intervention, we could try to compensate for what SARS-CoV-2 is undermining in the host response. Interferons, of course, are a type of pro-inflammatory cytokine. They don't directly fight viruses, but they are transcription factors that trigger multiple viral, especially viral, fighting properties of the immune system. And so it's a smart thing for a pathogen, a successful pathogen, to sabotage that. Here they point out 10 different protein products of this virus that either inhibit the induction in the first place of interferon type 1 or interfere with its signaling. And it just so happens that this is part of what keeps other pathogens in latency. So for example, more than 90% of human beings have multiple herpes strains in their body. Most of us are keeping them in latency most of the time, largely through an interferon 1 response. So the SARS-CoV-2 comes in acutely and for its own selfish reasons sabotages that interferon 1 signaling. But other pathogens are going to take advantage of that and change their virulence factors and perhaps sort of emerge from latency or from a non-replicating form. So here's an example of long COVID finding Epstein-Barr reactivation. Again, a majority of people have some of these herpes viruses. So we found that about a third of long COVID subjects versus 10% of control subjects were positive for EBV reactivation based on positive titers in IgG. So, this could be part of what, I don't want to overstate it. We don't know this, but this could be part of what is driving long-term symptoms. When these viruses reactivate, they move. That's part of their life cycle, is they move from the soma out to the terminals of nerve cells. They're neurotropic. Epstein-Barr, for example, acts as a transcription factor. Viruses don't eat or poop, right? So they have to take control of the host machinery. So Epstein-Barr has been known, for example, in a study out of Cincinnati Children's, to act as a transcription factor on the risk gene site for several chronic illnesses like rheumatoid arthritis, lupus, right? So it actually hijacks the genetic machinery at those sites. And so this may be part of why some forms of chronic illness emerge from this type of acute infection. And this is an old story. So this is back from 1989, active Epstein-Barr virus, and again, post-viral fatigue syndrome. So the idea that some particular virus, maybe not known in all cases, was sabotaging the immune system and other pathogens took advantage, which can happen at a really big picture group level, I think, that I'll talk about in a moment. And this is just the idea that herpes viruses move around in the nervous system when they are allowed to emerge. Think of when you get a cold sore when you're sick, right? They take advantage, and that is quite possibly happening internally, right? Shingles or cold sores you can see, but that kind of thing may be happening internally. I wrote a little bit about this in a hypothesis paper years ago. I would never say that this is the story of chronic fatigue syndrome. I don't think there is a the story, but I was trying to articulate a mechanism that I think is important, at least in some cases. And I think there's pretty good evidence that it is important in some cases of this diagnostic label. So a dysbiosis of the microbiome relates to that topic of the immune of SARS-CoV-2 acting as an immune saboteur. So just driving home the idea that human beings are not sterile. When you are infected with the SARS-CoV-2 virus, it is not entering a sterile site. There's a lung microbiome, oral microbiome, nasal, et cetera. And there exists a pattern where, for example, the vaginal microbiome predicts whether or not the HI virus will uptake in people. So the existing microbiome is part of the story of whether people get infected in the first place, and then how bad it is when they do. So here's a tissue level atlas of the healthy human virome, healthy human again here. So this is from a Japanese group, and this is just showing in multiple tissue types. These are all tissue types across here, and they're showing the different, in this case, it's just viruses. So they're using next generation sequencing here. Same is true with other potential pathogens. We call them pathobionts, like bacteria, archaea, fungi, etc. These are healthy people where they found Epstein-Barr, HSV1, varicella zoster, the HHV6s, et cetera, a whole bunch of different viruses that are in an uneasy truce with these healthy people. So they're managing them okay, but they probably will sort of spring to action whenever they get the chance. And the level to which this is a story, I think, is really underappreciated at this point. Again, I think this is where things are going to go over the next decade. So this is a paper that just came out last week from David, Amy, and Nikos are colleagues of mine, and they simply characterized stool. So they found more than 54,000 viruses in people's stool, 92% of which were previously unknown to science. So it's a vast ecosystem story. In this case, they're focused on bacteriophages, which are viruses that infect bacteria. So there's a whole Serengeti happening in our body with sort of an ongoing fight for survival, including sometimes working together, which I'll talk about in a moment. Pathobionts are organisms that can change gene expression and virulence factors. So, bacteria, when they are activated, can even, grow a tail. They can change activity. So if you look at the presence or absence only of pathogens, you're going to get half the story. You have to look at their activity, which can be shifted by an acute infection. So we know that that's true in COVID-19. This is, again, a preprint, but showing what I think is obvious if you dig into it, that an acute infection can change the behavior, like a disruptive kid entering a classroom can change the behavior of an ecosystem that is previously at a sort of an uneasy truce with the immune system. So here's that actual paper where they're talking about an increased risk of bacterial problems in the acute illness. So, how do we get to this? When all these problems are happening, how do we get to a situation where they're driving those sort of similar symptoms, like broadly speaking, the feeling of being sick, autonomic pain problems, failure to recover from exercise? How do we end up at that same point? Well, I think part of that involves, I'm a neuroscientist first and foremost. So of course I'm focused on the central nervous system, but I think any subjective feelings like that probably are based in the central nervous system. And it does involve inflammation, which is something that is detected by the central nervous system and relayed. So I want to get a little bit into the neuroscience of feeling sick. So what causes us to feel sick and to have those subjective sensations? So I'm kind of focused on the dorsal brainstem. Here's a picture of me in sagittal. I'm a terrible subject. I move a lot in the scanner, so this is blurrier than they normally are. But normally our images are nicer than this. But I'm going to blow it up a little bit and do a Photoshop version of brainstem. And here's with some anatomy imposed on it. So let's grow it up a little bit so we can look right in that one area kind of here in dorsal brainstem, right near the vermis of the cerebellum, kind of below the fourth ventricle there. There's a whole bunch of structures and circuits that are in close proximity there. And I think it may be sort of important for some of these symptoms, why people feel sick. So it's the nucleus of the solitary tract is something I want to focus on. If I highlighted it here to show how central it is to these other nuclei that I'm going to talk about in a moment. So it's the site of the sensory vagus nerve soma that respond to the detection of peripheral inflammation. I'll get into that in a little bit in a moment, but essentially the vagus nerve acts as a diffuse sensory organ for the central nervous system that detects peripheral inflammation and relays that to the central nervous system to trigger the feeling of being sick, the sort of go home, go to bed signal. It's where a majority of the afferent vagus cell bodies lay. And here is area prostrema, which is a circumventricular organ. So around the ventricles, it's one of, I guess, 7 circumventricular organs, which are little fenestrations or windows in the blood-brain barrier that allow sampling of macromolecules. But that also makes this area a little bit vulnerable during a sort of an acute sampling. It's a central structure for vomiting and nausea. For example, a lot of our folks do experience that. I wouldn't want to directly tie it to some problem here, but it's a circuit that triggers that subjective feeling. So the vagus nerve, vagus shares the same Latin root as vagabond, meaning to wander, right? It wanders all over the body. It innervates most trunk organs. And basically what it does is it allows the central nervous system to know what's happening in the trunk and gut especially. It detects peripheral catecholamines, for example. Catecholamines don't easily cross the blood-brain barrier. So when you have an adrenaline rush, that's largely because it was detected by the chemoreceptors of your vagus nerve, which then triggers an afferent signal to signal the locus ceruleus, where norepinephrine is made on the brain side of the blood-brain barrier. But it's an example of how it functions as a sensory organ. It also detects local immune signaling molecules like cytokines. So cytokines they're not massive proteins, but they're certainly not small, and they're lipophobic. They don't easily cross blood-brain barrier. And yet we know that they can affect the feeling of being sick. Well, they can do that not because they easily cross the blood-brain barrier, but because they're detected by chemoreceptors on the afferent vagus nerve. Vagus also surveys gut microbiome on an ongoing basis, and it initiates the central illness response. So we know this from careful rodent studies, especially from Linda Watkins and Lisa Goler, our 2 sort of giants in that field in the mid-90s. Essentially, if you take a rat and let's say inject them with E. coli, direct infection, or IP injection, or inject them with something that mimics an infection like lipopolysaccharide, or that mimics a response to infection like cytokines, the rat will act sick. It will stop running on a wheel. It won't eat as much. It won't socialize. unless you've cut the vagus nerve, and then it acts normally. Its brain doesn't know that its body is sick if you've clipped the vagus nerve. You have to do it down lower, you'll just kill it, but subdiaphragmatic. So this is a really important circuit for the feeling of being sick, and I suspect that happens on a long-term basis in people that are suffering from chronic illness. And we can measure this with PET, which I'll talk about in a moment, and to a lesser extent, magnetic resonance spectroscopy. So let's just talk a little bit about the immune system here, like monocytes and macrophages, just as exemplars. So here's the blood-brain barrier, which again, just is a lining of the vasculature. It's not like a barrier at the neck or something like that. But when these immune cells either directly detect pathogens or detect some mediators that other immune cells are responding, they activate, they enter a state of activation, which I'm symbolizing here with the red. They release immune mediators like pro-inflammatory cytokines, most of which don't just passively diffuse across the blood-brain barrier because they're relatively large molecules that don't particularly easily cross the lipid bilayers. So one of the ways that they get around, that the signaling works here, is through circumventricular organs, including the area postrema or choroid plexus or any of the other ones. So they can directly cross, or interestingly, the immune cells themselves can be taken up via active transport across some of these sites. So it's one of the things that we've seen in COVID, in acute COVID, is that there's a lot of immune activation and possibly even virus in right around the area of this dorsal brainstem at the place in the lower brainstem where cranial nerves branch, right the area that I was talking about. Not all pathologists have been finding this. There's been a lot of focus on inflammation again, but this is the most systematic study. I talked with the lead author a little bit, and he said it was a very rigorous peer review process, 8 peer reviewers on this. He said it was one of the more difficult peer reviews he's ever experienced. Overall, at the very least, we know that astrocytes and microglia, some of the innate immune cells of the central nervous system, can activate, and even circulating immune cells can infiltrate, often through these circumventricular organs, including area postrema. And this is also something that primes glia. Glia means glue in Greek. It used to be thought that they just held neurons in place, but it turns out there's all these immune properties as well. They can become primed, which is something that I'll talk about in a moment. So beyond direct active transport, the vagus nerve is involved. So the chemoreceptors on the terminals, which are all over the place, remember, they're all over the trunk. So if there's a small amount of inflammation in one area of the trunk, it's going to get detected by the highly branched, very sensitive vagus nerve. And that triggers what's called a mirror response of activation on the brain side of the blood-brain barrier. This is what triggers the feeling of being sick. This is the pathway that causes us to feel sick and worn down and wiped out and that sort of thing. Again, if you clip it in rats, they don't feel sick even when you've given them an infection or injected them with inflammation. So the vagus nerve's highly branched structures allows the detection of local immune signaling. So again, a big problem is that you may not detect these immune modulators in sort of an endocrine level floating through blood in a higher level. They're paracrine signals. Interleukin means among white blood cells, right? So they're paracrine signalers as opposed to endocrine signalers. So the response can be local and it will still be detected by vagus. It doesn't necessarily have to be infectious. The same thing happens with injuries, which I think is maybe important for some long COVID folks who are surviving just tissue damage from that acute virus. Maybe the virus did fully clear and they're just dealing with an illness, or excuse me, an injury in some cases. There's a mirror response on the central nervous system side. And that's been reported in ME/CFS. This is basically a pilot level study. I don't want to overstate this. It's N of 9, but they used the radioligand PK11195 to detect glial activation right there in the sort of mid pons. A pretty good separation between their subjects and their healthy controls. I'm replicating this study now using, and I'm super glad this group did this, but I'm using a little bit more updated methods to replicate with larger numbers, including now in long COVID. So these other structures that are nearby the nucleus of the solitary tract where vagus enters and the area postrema where macromolecules can cross include the dorsal motor vagus, which is a site of autonomic function. It's where parasympathetic soma lie. It's the main source of vagus output, the efferent branch, innervation of trunk organs. The dorsal reticular nucleus is a site of inflammatory pain transmission. That's a real common problem. That's the myalgia of myalgic encephalomyelitis that people report. The ventrolateral medulla is involved in noradrenergic sympathetic nervous system signaling, autonomic control of blood pressure and breathing. Again, autonomic problems are common in these chronic illnesses. There's also some evidence of small fiber neuropathy, which is at the peripheral side of things, as opposed to the focus here, which is very central, which I think is worth looking at in long COVID as well. Are these folks going to develop problems, reduction in C fiber density, both pain and autonomic C fibers out in the periphery, which is something that we see in fibromyalgia, ME/CFS, et cetera, again, not in everybody, but in a higher than would it be expected percentage. Nucleus ambiguous contains the soma of the cholinergic pregangliotic neurons that control heart rate, again, tachycardia, autonomic problems. So just to drive the point home, this is Lisa Goler and Ron Gakema's work. So they basically squirted food poisoning bacteria down a rat's gullet to sort of mimic. And what they showed was in the nucleus of the solitary tract, this is CFOS protein induction, which is sort of a proxy for neural activation. It's an immediate early gene that turns on when neurons turn on. In the rats, they found in the nucleus of the solitary tract, in the infection, but not the saline controls, an activation in area postrema, nucleus of the solitary tract, and in some of those autonomic sites as well, including ventrolateral medulla. So here they're just saying that the left panels represent the infection and the right panels represent the saline controls. This is the sickness circuitry that causes a rat to feel tired and worn out and not want to run or not want to eat as much, not want to socialize, et cetera, et cetera. That's the reason they feel sick. So here's some stress responsive structures from the same experiment, where A versus A prime is the infection versus the saline. And they're showing it in central amygdala, bed nucleus, the stria terminalis, insular cortex. These are locus coeruleus. These are structures that are very stress responsive, associated with anxiety and depression. And again, I would argue that these rats don't feel sick because they're anxious. They have, to the extent that rats feel anxious, they have anxiety and stress related circuitry activated directly by these pathways. And that is the reason for their now I'm moving to humans. That is the reason for human subjective experience of anxiety and depression in these chronic illnesses. It matters, you should address those problems. But I think one of the struggles we've had in ME/CFS is to not psychologize people simply because they're chronically ill and depressed. That we have a causality arrow that's too often pointed in the wrong direction. And here's just an example of the vagus nerve. It's a review article. It's a vast literature, really. This is an example of the vagus detecting the gut microbiome per se, which again can be driven to a pathobiosis by an acute infection. And just to shamelessly plug this study again. Again, I'm not going to argue that this is it. This is the story, but it's a mechanism that I think is important. So all of this leading to what I called the mirror response on the brain side of the blood-brain barrier activates these glia, microglia, astrocytes, et cetera, on the brain side. And they undergo something that's called glial priming, which is a really interesting phenomenon that I'm going to talk about here. So, when you look at a brain sitting there on a table, a large proportion, the majority of the cells you're looking at are glia. So they're more than just giving support to neurons. They're an a little mini immune system as well. So here's just sort of a standard microglia that I tried to draw with my keynote. So they're the resident macrophage of the central nervous system. So they develop from the sort of yolk sac early on, in the same way that the resident macrophages of other tissues develop and then move into those tissues. So again, when there's some infectious insult or inflammatory insult, like that mirror response, they activate. And I'm trying to show this by some morphological changes, which they do undergo. They sort of like, they're less long and spindly, and they get like sort of these fat arms. We're well beyond M1, M2 phenotype at this point. It's much more complex than that. That's an oversimplification, but there are states of activation that they can enter. So when they do that, they activate and they produce cytokines, which are my little triangles here, and other neuroexcitatory modulators. So they produce, for example, glutamate, ATP, bradykinin, prostaglandin, nitric oxide, a whole bunch of things that excite neurons. Now, if you think about it, that's going to disrupt the normal, exquisitely sensitive signal to noise of neurons that allows us to pay attention, that allows us to solve problems, et cetera, et cetera. So that may be part of what's happening with the brain fog. One of the things that they produce is this thing called TSPO, or the translocator protein, sometimes called the peripheral benzodiazepine receptor. But this is a thing that we can detect with PET imaging. So that Nakatomi 2014 paper that I showed you earlier used a radioligand called PK11195 to detect the translocator protein in patients. And like I said, we're replicating that. Causes immune signaling, causes neuroexcitation. This is the reason that about 10% of relatively severe brain injury patients end up in seizures, right? There's a lot of neuroexcitation happening, and it produces the translocator protein. So once they become active like this, they enter a state called primed, right? So now I've drawn this as though it's a morphological state. We cannot yet identify a primed microglia. It's a functional state. So we know that a microglia has been primed by challenging it with a subsequent second challenge, right? And let me show you what that means. You've got a primed microglia that has recently had an inflammatory insult of some sort. Microglia tend to be relatively long-lived, astrocytes too, where they're post-mitotic. They're often in our central nervous systems for a pretty long time, and then they are not. It is not the case that they're replaced by circulating stem cells. So it's the kind of thing that maybe, we don't know this, but maybe is part of the story in these long-term chronic illnesses where they sort of enter this state. So when a primed microglia, again, has an infectious or inflammatory challenge, they have a bigger, bolder response than the first one, right? That's, hopefully you're seeing that I created more little lightning bolts and cytokine triangles. And interestingly, priming can happen in utero even. So we know, for example, that things like diesel exhaust in utero prime microglia in the offspring. That's a rodent model from Stacy Bilbo at Duke, who's done some good work. She was at Harvard Med for a while and now is back to Duke. Again, we don't know this, but this is the kind of thing where, unfortunately, our society is organized under, really important racial boundaries, where there's a lot of sort of environmental racism happening, where non-white populations are more likely to be living near pollution. That's beyond just highways, but it's also polluting industries and things like that, right? And these sorts of dynamics even affect things like insulin sensitivity, anxiety, things like that. So it may be an important vulnerability factor that happened in utero. Again, we don't know that for a fact. But if microglia are primed in utero and someone then has an inflammatory insult later in life, they may have worse long-term consequences than someone who did not have primed microglia early on. And that interacts, by the way, with nutrition and diet and maternal stress. Something to think about. So I wrote a review article about how to study this stuff. I think it's just really important to do it right. There's a lot of sort of slightly less than ideal studies that add a lot of noise to the literature. So, this is something that we're working on. And, like I said, we just scanned our first long COVID patient about 2 weeks ago. And this patient qualified for an ME/CFS diagnosis technically, although we knew the onset in this case. So Ava Ratai is a collaborator here at the Martino Center for Biomedical Imaging, where I am now. And she is a spectroscopy expert. So that can use MR instead of PET, which is nice because you don't need to inject radiation or use an arterial line. And you know, she's interested. She was there at the scan helping us out. She's a pro. You know, that first subject that we scanned, he had to drop out of law school. You know, when he hears psychological explanations, he's really frustrated. He's like, I was going to be making 200 grand a year, man. You think I want to be on disability, getting my brain scanned? I mean, you're the one that's nuts if you think that. So just worth thinking about. Basically, what Ava can do is to show differences in magnetic resonance. So it's similar to, you know, sort of normal spectroscopy with light, with chemicals showing different diffraction patterns. Magnets do the same thing. So chemicals have a different magnetic property when they're measured by an MR, and we can measure things that are associated with cell division or brain health. Creatine, choline, myoinositol is associated with inflammation. NAA is associated with neuronal health, even glutamate, which may be associated with glial activation. So I want to talk a little bit some data, and I show myself at minute 50. So, but I also show that I'm about 4 minutes to 3. So I'll try to go through this a little bit fast. So this is Phoebe Chan working with a grad student, Ceci. What Phoebe has created is essentially a model where she took all of these different peripheral measures. Here she's taking a middle cerebral artery Doppler and creating a regressor model that predicts the cerebral blood flow. So in the scanner, we put people in there, and what we're showing is that the blood flow in the brain and those peripheral measures are really tightly correlated. It's to be expected because we made it this way, right? But what we do is we give them a little challenge, a hypercapnia, which ought to cause some vasodilation. And it shows here that this correlation holds even during this mild autonomic challenge. So this is essentially a heat map of correlation. Red means it's correlated. So in an ME/CFS patient, it's disrupted. So we show a weakened correlation at baseline, but when the breath hold comes in, it really just collapses. So we're not having the same central nervous system response as we are in healthy patients. Interestingly, it's not the same in everybody. It's not precisely the same. It's disrupted, but it's not precisely the same. So here's another subject. Here's one where it really collapses under breath hold. So you sort of get the point here. It takes a challenge and some careful measurements to figure out what's going on in these patients. You can't just do a blood test. So some more examples here. And something I just wanted to briefly touch on is the idea of the perivascular spaces, sometimes used synonymously with Virchow-Robin spaces, although they're not precisely the same thing. As blood vessels penetrate from the outer skull into the brain, they're surrounded by these spaces through which interstitial fluid and cerebral spinal fluid mix and end up being the sort of lymphatic system of the brain. Here's just another schema of the same thing in a different review article. Surrounded by astrocytes, particularly, is there a form of glial cell. We see enlarged perivascular spaces in our patients. So these little sort of white dots here, here we're showing them in basal ganglia, which is type 1. Some more here in this woman. You know, you can't just look at that and say, ah, yes, there's the chronic fatigue syndrome. But it is something that you're seeing. This is a 39-year-old male, and it just shouldn't look like this. It looks like someone took a Tommy gun to his brain with these enlarged perivascular spaces. So we think that this may be part of sort of a vascular and even lymphatic flow problem. There is some evidence of enlarged perivascular spaces in COVID, and it's really interesting to see if it holds for long COVID. So I'm just going to show a couple more. And the type 3 is red nucleus. Interestingly, in autism, this is autopsy. So Matt Anderson of Harvard Med, this is healthy, and these are autism. He showed enlarged perivascular spaces with with basically immune penetration. Same thing with, this is David Gates' work in Alzheimer's. So again, showing enlarged perivascular spaces with penetrating immune cells interesting here, he showed in cerebral spinal fluid that they were responding to Epstein-Barr virus. So the point that I'm trying to make here is that there's an immune penetration that's happening for a reason. And with that little speedy end, I'm going to just thank my collaborators and thank you guys for watching.
That was an amazing tour de force. Not sure we have any time for questions, but
yeah, I blew through that. I'm sorry to not leave you time to ask questions.
Well, if people would like to stay on for a few more minutes, and if Mike can stay on, I'm willing to as well, if anyone has questions.
Yeah, happy to stay on.
Yeah. I have a question. I don't know if you have time to stay for a moment.
Yeah,
okay,
for sure.
Great. All right. But so thank you for the presentation. It was really helpful to learn more about the neuropathology of the disease. And so I guess for me, one thing we've thought about for my project is beyond diagnosing ME/CFS patients, how do we actually find the patients in like observational data such as EHRs? And so given COVID, like, do we see an increase in the specificity and like how the disease is being diagnosed? And like, are there particular tests or criteria that would be valuable to look into to then improve how we define a patient sample?
It's a symptom-based syndrome diagnosis,
Right.
and quote unquote misdiagnosis is just a big problem. So there's a lot, and it's really maddening too, because when people get the label, it kind of gives MDs an excuse to say I give up. And so we've seen cases where a kid was diagnosed with ME/CFS and later on figured out that they had a milk allergy or something like that. So it's a label where there's sort of a belief, I think, that it's this strange, mysterious thing, which I don't think it's really actually all that mysterious, but it is based on their subjective symptom report. The definition that I use is the international consensus criteria, which I think is, I would argue, the strictest and best. So I don't know how you get at it without seeing that they're complaining about feeling like they're not recovering from exertion particularly, but also showing some of these sort of pain, subjective autonomic reports. I don't know enough about medical records to know what you'd be looking for, to be totally honest, but
Right.
that's the unfortunate answer, is that it's currently there's no real blood test. The best test we have right now is a 2-day exercise test, which is just, first of all, it makes them feel sick, some of them, for several days afterwards, sometimes even longer. But basically VO2 max drops off on the second day of exercise, not the first day. They show normal effort, and they're just failing to oxygen extract on day 2. So yeah, I wish I had a better answer where you could just look for some protein, but that's sort of the
Right.
whole problem, right? Is that it's this sort of subjective report.
Right. No, that totally makes sense. I think that's like an ongoing challenge across a lot of us working on ME/CFS.
yeah, there's a really interesting report that patients with MS on fingolimide don't respond to the vaccine. And fingolimide, of course, is a very good anti-immune medicine for MS. And I'm just wondering if, maybe there's some kind of correlation between immune responses we see in MS and immune responses we'd expect in ME/CFS.
Yeah, I mean, it's that sort of, I would argue, an incorrect dogma of the hyperactive immune system. It's responding to something, and finding out what that something is, I think, is the crux of the research goal. But yeah, I mean, some ME/CFS patients haven't been responding particularly well to the vaccine because their immune systems are kind of like churning and going. I personally think, and there's disagreement on this, that it's trying to do something, but when you add an additional immune stimulant, sometimes the consequences aren't really great for those folks. So they struggle sometimes with having emerging symptoms upon getting an additional immune stimulus. I mean, vaccines are supposed to mimic infection, right? It's a sterile infection, of course, but they sort of mimic the immune response of infection, or else they wouldn't work. So yeah, I mean, it'd be interesting to see if these folks are creating antibodies appropriately. I don't know the answer. I know.
I mean, apparently they're not. They're not.
Yeah, I wouldn't think so.
Yeah, right, and the thing is, it's very specific to that, which is a sphingosine phosphate, I think, receptor blocker. And so, of all the anti-immune medicines that we use to treat MS, I mean, that seems to be the one that is decreasing the response with the vaccination. So it's just very interesting that maybe there's something with that receptor.
Yeah, that's really interesting. It's a tough problem for people because they're prone to viral infection. Most of these patients desperately want to get vaccinated. They're prone to viral infections. They get hit worse than others. They have longer term problems and others. They sometimes get an infection and then recover, but it often takes longer. But they have that exact dilemma of, I bet I'm going to have bad responses and not even make a antibody response particularly well.
Any other questions?
Ben's turning up.
I had one. Mike, this was really fantastic. Thank you so much. I had a question about correlation to severity in the acute phase. I saw this MRI study out of Oxford where they showed gray matter involvement in the limbic system close to the olfactory mucosa and but in post-acute COVID sequelae, long COVID, are neurological or neuropsychiatric symptoms correlated to disease severity?
I don't know the answer to that, but a big immune challenge like that, especially something that affects the vasculature so much, it's such a huge problem in COVID. Obviously, vasculature of brain is super important. I mean, just it's the reason that you can kill somebody in very quickly with a carotid, neck hold. So yeah, I mean, I strongly suspect that the initial acute vascular response can lead to long-term consequences in these folks. And it would be really interesting to see if that holds up. I don't know the answer, but I bet. I mean, it just sort of fits how I think about it and what makes sense to me.
Anybody else? All right. Well, thanks everyone for staying longer. And thank you, Mike, for your talk, which was extremely informative and a lot to think about. So thanks, everyone, and we'll see you in 1 month.
Thanks all. Keep up the good work.
Bye.